Hello again to yet another video of studying anatomy. So I'm sorry for the disturbance that we had in the previous class. I could only complete till here because I had an unavoidable disturbance. So I think let's continue from here only. We were studying about the femoral triangle. As far as I remember, we just completed it. I was explaining about the floor. The floor is formed by these three muscles. The apex is formed by the joining of Sartorius and the Adductor Longus. Medial border is Adductor Longus, lateral border is the Sartorius, and the base is formed by the Inguinal Ligament, right? I hope everybody remembers till here. Let's get to the next topic, that is gallbladder. See, what I've observed is that if you've given NEET PG exam, you will find it very easy to study because the content is very superficial. So it is going to be easy if you've already prepared for the exam, because the detail that we study in while we are preparing for NEET PG related, I mean, if you compare that with the MRCEM part 1 exam, it is relatively easier, right? But we still need to study because there are few topics that we might not have read in NEET PG, but we will have to read here. So see, gallbladder. What is gallbladder? Gallbladder is a fibromuscular sac. Can't believe that this was also a question once. So what is gallbladder? Gallbladder is a gallbladder is a fibromuscular sac. Fibromuscular sac. Very interesting imagination that I have to tell you. See. Just imagine, this is the gallbladder, right? This is the cystic duct, and then it comes from the hepatic duct and it forms the common bile duct. Then it enters into the duodenum. I hope you remember. Now what happens is, when we are eating, the postprandial or the prandial phase, at that time the bile comes out from here, comes into the duodenum, into the jejunum, and then it gets mixed with the food and starts all the digestion process that we've always studied of. But what happens when we are not eating? See, you are eating. I had my lunch at around, let's say, I had my breakfast at 8 a.m. Now I haven't had my lunch yet. What happens till 8 to 2? So after 8 a.m. what will happen? This sphincter of Oddi, this is going to close. Okay. So now just imagine, this is a very interesting thing. I never actually really thought about it in this way. So I thought maybe all of us must have not thought about it in this way. So what happens is, as soon as we interprandial, basically I'm saying the fasting period, what happens during the fasting period is that the bile will keep flowing from the liver, right? How will it go retrograde? It won't. So what happens is, bile keeps flowing, it keeps filling here. And when it reaches here, it keeps filling here, and then it reaches the gallbladder. And then when it reaches the gallbladder acts as storage function. So whenever this sphincter of Oddi will open, this much of bile is going to rush. And then the CCK, if you know, cholecystokinin enzyme, that causes the contraction of the gallbladder wall for extra bile that we might need. So any extra bile that we need comes from the gallbladder later. So if you can imagine that in the fasting state, always our common bile duct is full of bile. And then retrograde movement of bile occurs, and that's how the gallbladder gets filled up. So this is what I wanted to tell, because this was mentioned somewhere. So I thought that let's think about it once, because bile flows out of the cystic duct this way, and in the interdigestive period, this pressure forces the bile up. I hope you understood what I just said. This pressure will force the bile up, and that's how it will reach the gallbladder. Okay? I've made it quite messy, but please, you need to understand this. Now, what is anterior to the gallbladder is the liver. I hope it's very, very easy. Then what else do we need to know? And the anterior abdominal wall, of course. Posteriorly, there is going to be the transverse colon. Please imagine, there is going to be the transverse colon. Aisa. Transverse colon. What else? First and second part of the duodenum. And inferiorly, what is there? Inferiorly, there is the biliary tree. And 2 to 4 part of the duodenum. Okay. So this is how it is, more or less grossly this is the picture. So let's get to the next topic now. GI tract histology. It is such an easy thing. All we need to know is that there is mucosa. The innermost layer is the mucosa. Then there is the submucosa. Then there is the muscularis mucosa, and then there is the serosa, right? Now the mucosa is again divided into three parts: the mucosa, epithelium, lamina propria, and muscularis mucosa. Then the submucosa, this what we need to know is that this contains, I've written it, yeah, it contains the Meissner's plexus. Meissner's plexus. So what does Meissner's plexus do? It causes secretions. Then we will come to the muscularis, muscle. Wherever there is muscle means myo. I hope you know myometrium, myocardium, myoglobin. So myo word is related with muscle. So muscularis has Auerbach's Auerbach's plexus, or it is also known as Myenteric Plexus, where my stands for myo or muscle and enteric means the enteric system or the alimentary canal. So in the muscularis muscularis layer, there is the Auerbach's plexus or the Myenteric plexus, whereas the Meissner's plexus, which is associated with secretions, is in the submucosa. You can also remember it as submucosa, secretions, Meissner's, SSS also you can remember if you want to. That's how I used to remember. Now serosa and adventitia, there is just one thing that you need to know about it. The serosa is also known as adventitia when the organ is retroperitoneal. So if there is a retroperitoneal organ, what are the retroperitoneal organs, by the way? I'll take it up later here. So the ascending and descending colons, if you know, the transverse colon is intraperitoneal, but the ascending and descending colon are retroperitoneal. So these two, when the serosa layer is there, it is known as the adventitia, and it is known as serosa for all the organs which are intraperitoneal. I hope you got this small minute point. It is important, that is why I have mentioned, otherwise I really find it very boring. So this is about the GI tract histology. Let's go to the next. This is the gluteal region. So in gluteal region, we need to know the muscle, their innervation and their action. So I have a small mnemonic, Latin. No, this is not for here, I think. Just a second, no mnemonic, sorry. See, there is the gluteus maximus, there is the gluteus medius, there is the gluteus minimus, and there is the piriformis, right? Now you just have to remember one thing. Medius and minimus always goes together. Maximus goes opposite to medius and minimus. Did you understand what I just said? Maximus goes opposite to medius and minimus. Medius and minimus always goes together. Now let's talk about the nerve supply. I know it's very irritating to know that gluteus maximus is supplied by the inferior gluteal nerve, whereas medius and minimus is supplied by the superior gluteal nerve, and piriformis is supplied by nerve to piriformis. Not very important, right? So this is the innervation that I was talking about. Now let's look at action. So gluteus maximus is for the external rotation, which is known as the lateral rotation of the thigh. So external rotation is by gluteus maximus. So what will medius do and what will minimus do? They will cause just the opposite of what maximus does. So maximus does external rotation, medius and minimus will do internal rotation. Easy? Was that easy? Yeah. Is there anything else? Yeah. Also causes the abduction of thigh. Okay, here one more thing we need to know about the gluteus maximus, that it has an iliotibial tract, if you remember iliotibial tract. So through iliotibial tract, this muscle also supports the extended knee. So whenever the knee is in extended position, especially when we are standing at that time, the knee is supported by the iliotibial tract, where some of the fibers of the gluteus maximus takes its insertion also. So this is a special extra point that I told you here. Otherwise, you have to remember that the gluteal maximus is supplied by the inferior gluteal nerve and causes external rotation, whereas medius and minimus goes together, supplied by the superior gluteal nerve, causes the internal rotation. What does piriformis do? It causes external rotation again of the thigh, external rotation of the thigh, and the other thing that it does is abducts the flexed thigh, abduction of thigh. So it is basically doing both, one action of gluteus maximus and one of gluteus medius and minimus. Okay, so this is about it. Let's go to the next topic now. The greater omentum, very small topic, very limited things that have been written about it. First function is, if you remember, it is also known as the housekeeper of the abdomen because it limits the infection. So if you have read BD Chaurasia or any other book in your first year, just like me, you must have remembered that it is known as the housekeeper or the policeman of the abdomen, something like that. It limits infection. That is the first very important function. Second is it has immunity function. So immune function, this is the second thing. And then the third one is adipose tissue storage, of course. Whenever we get healthier, what happens is our tummy comes out, right? So this is the adipose storage. It is a huge source of adipose tissue. So this is about it. Where is it attached from? It is attached from the greater, this is the greater curvature. So from here it will fall down like a curtain. This is how you can see it over here also, right? This is the anatomy. I think that is all about the greater omentum. Now let's go towards the groin. So groin hernias. Groin hernia means what? That one thing that I always have hated, which is direct inguinal hernia, which is indirect inguinal hernia, which artery, why does it occur, all those things. So see, we are here to study 3 hernias all together, alright? So we'll be studying 3 hernias together. The first one will be direct inguinal hernia, direct hernia. Other one will be indirect hernia. And the third one is going to be femoral hernia. Now see, I have a small mnemonic. The mnemonic is Latin dime. Do you know what is Latin? And what do you know what is dime? If you don't, no problem, please remember. So Latin is lateral to inferior epigastric artery. Which hernia? Indirect hernia. Then dime, direct hernia, is medial to the inferior epigastric artery. Did you understand what I just said? I just tried to explain you the mnemonic, right? So if I ask that direct hernia comes through, does it come lateral or does it come medial to the inferior epigastric artery? See here, I told you that it comes medial. So direct hernia comes medial to the inferior epigastric artery. I hope that makes sense now. Indirect hernia, indirect inguinal hernia is lateral. So it comes lateral. I had such a hard time to remember this fact. So I am just trying to make it simple for you all also, because I just sat down with this once and just thought I need to make a mnemonic for it right now and make it clear for myself today. So lateral to the inferior epigastric artery is the indirect hernia. Then what about femoral hernia? Femoral hernia is below the inguinal ligament. Yes, we need to remember this. Below the inguinal ligament, lateral to the pubic tubercle. This is how the question will be asked, that the site of hernia protrusion is below the inguinal ligament, lateral to the pubic tubercle. So what hernia could that be? So you will keep wondering that Dr. Vidushi told that Latin and dime, I don't know now what they've asked here. So please remember that the femoral hernia will be below the inguinal ligament, lateral to the pubic tubercle. Okay, now let's talk about cause. Femoral hernia, we don't know any causes. direct and indirect hernia have their own set of causes. Okay, so direct hernia cause is the weakness in transversalis fascia. Okay, please remember that the fascia transversalis is weak, and that is why loop of intestine is able to come out of it through it, and that is how hernia occurs. Okay, where is it weak? Is it weak everywhere in the body, like everywhere in the abdomen? No, it is weak in the area of Hasselbeck triangle. What is Hasselbeck triangle? Please don't ask me, go and read about it. So area of Hasselbeck triangle, in that area, whenever there is weakness of the transversalis fascia, it causes direct inguinal hernia. Indirect hernia, on the other hand, causes, the cause is the failure of processus vaginalis to close. Processus vaginalis to close. Did you understand this part? Here nothing. Okay. Which of the following hernias has a higher risk of strangulation? So you have to remember that the femoral hernia has higher risk. See, these are questions, right? I'm not telling you here things that won't matter. These are not unimportant stuff. See, I cannot cover the entire syllabus. It is humanly impossible. I've only picked up those points where I found that there were number of questions asked. So I just took those topics and I have just tried to tell you only those points which you need to know. So higher risk of strangulation is with the femoral hernia. Now, what else do we need to know? These two are common in males, obviously, and this one is common in females. How do you remember that? Females will have femoral hernia. Very simple. I think all of us know this by this mnemonic only, by this trick only. Which one can occur in infants? These are questions. So indirect hernia occurs in infants. Okay, do we get that? And what else? Yeah, these two will occur in adults. That is all that I have here. Let's go to the other topic now. This is the portal vein and the portosystemic anastomosis. So see, there are 7 sites of portosystemic anastomosis. Do you know what is the portal vein? See, there are 2 types of venous systems in our body. One is the inferior vena cava, superior vena cava, which comes to the right atrium. Then there is the other one, which is the portal venous system. So what happens is the inferior mesenteric vein and the splenic vein come together and they form the portal vein. What is important about it? See, in case of poisoning, in case of anything that we eat, what happens that whatever we eat, it gets absorbed in the intestine, right? Now what happens from the intestine, all that food gets into the blood. Now from blood, where does it go? Can it go directly into the body? Huge no. Nature has made a protective mechanism. Whenever we eat something, that thing goes directly into the portal vein, into the liver. Directly. Okay, why? Because our liver needs to know if this thing is permitted to go into the body or not, right? If it is a poison, if it is a high oxidative stress content, if it is something that might harm our body, our liver will clean it up. Our liver is going to break it down. It is going to decompose it so that it becomes non-toxic for our body. In simple words, right? That is why this portal vein is important. Now what happens is, why do we need to learn about portal vein and portosystemic anastomosis? See, what happens is, this is the pink one, if you can see. This is the portal vein, right? The pink one is the portal vein. So this must have been the splenic vein. This is the inferior mesenteric vein. Both of them come and forms the portal vein. Now what happens in case of CLD? CLD is chronic liver disease. The liver is unable to get so much of blood, right? Because it is getting fibrosed. Cirrhosis, right? So what happens is, it is unable to accept so much of blood. So at that time what happens, that the blood which is supposed to go into the liver and then again into hepatic veins and from there into the systemic circulation, it is unable to go. So what happens is, there is a reflux of blood. So blood comes back. Whenever blood comes to start back, blood begins to come back. It causes increased pressure, which is known as portal hypertension, right? So whenever there is portal hypertension, what happens is there will be increased blood supply to all the areas where there is portosystemic anastomosis. Why do we need to know about this? Because see, whenever there is a place where there was, it is not supposed to be having a lot of blood. But now what happened? There is a lot of blood. Why? Because there is backflow. There is significant backflow. What will happen now? There is going to be increased chances of bleeding. Plus, since it is CLD, since the patient is having liver damage, liver is responsible for making the clotting factors also, right? So, there is deranged INR, plus there is pooling of blood. So even a very minor trauma, which naturally does not cause any bleeding, may lead to torrential bleeding and even death, right? That is why we need to know about it. How many sites of portosystemic anastomosis do we have? We have 7 sites. You can see in the photo below. Where is one? One is here. See. Is it visible? So this is the esophageal varices, right? Esophageal varices. So at the esophagus, lower esophageal junction, you might know that most of the CLD patients come with hematemesis. So there can be a question like a patient who is looking icteric, who has ascites, and he has come with hematemesis. So what is the most likely source of bleeding? So that will be the esophageal varices. Okay, at the level of the lower esophageal sphincter, there is esophageal varices. This is site number 1. Now let's go to site number 2. Can you see here? This is the spleen. Okay, so near the spleen is site number 2. Let's go to 3. 3 is here. Okay, this is the rectum and the inferior rectal vein. So at the rectum also, there is anastomosis between superior and inferior rectal vein. So also there can be a complaint of hemorrhoids, right? If you've seen CLD patients, you might know that there is complaint of hemorrhoids, plus there is complaint of hematemesis. So hematochezia plus hematemesis we find very frequently in patients with CLD. Then which is 4? 4 is over here in the intestines, right? So this is known as the vein of Retzius, not very important. It is near the cave of Retzius, if you know, near the bladder. Not really need to know. Then this is the 5th one. 5th is the subcutaneous abdominal vein. Have you seen caput medusae? Have you heard about it? Let's suppose this is the umbilicus. So what happens is you can actually see dilated veins, tortuous veins around the umbilicus, bluish colored, and this is known as the caput medusae. This is the 5th site of the portosystemic anastomosis, which is the anterior abdominal wall. It is between the paraumbilical vein and the subcutaneous abdominal vein. Okay, then 6th one is the bare area of liver. See here, it is known as the bare area of liver. Okay, it is between the veins of Sape. We don't need to know much about it. And the 7th one is here, omentum. So near the omentum also, near the greater curvature, there is the 7th. We don't need to really know about this also. The main 3 that we needed to know is the esophageal varices, the rectal varices, and the anterior abdominal wall varices, right? Do you understand all of this? Is there anything else that I need to tell you here? Retroperitoneal, paraumbilical, intrahepatic, rectal, esophageal. Yes, I've told you all of them. Caput medusae also I've told you. So see, this is all about it. Now let's go towards next one. What is this? This is the inguinal canal. Very irritating topic again. I really hate this topic. I don't know why I've put it here. I just hate to teach, to learn, to read about this. But let's go through it. This is a very nice image I found. I really thought while picking this image that I'll be able to understand. But it looks so difficult to me now that I don't really think I'll be able to see. Let's break it simple and let's just stick to the questions that are being asked. So which is the inguinal canal over here? Can you see this thing that is coming till here? Are you able to follow? So see, it is actually between so many muscle layers. So the inguinal canal is not just between any two. It is actually between so many muscle layer and so many aponeurosis also. So what is asked about is the contents. Contents of, yeah, I'll have to write here only. So the contents of inguinal canal. So do you know, are you aware of the contents? It has nerves. You will have to remember this with me right now because I won't be able to write so much together. It has nerves, it has arteries, it has fascia, it has 3 other things, and it has, that is all. Okay, so what are the nerves? 3 nerves, 3 arteries, 3 fascia, 3 other things. That is how we used to remember. So which are the nerves that we need to know? Can you see any nerves here? No, I don't think so. So the nerves are genital branch of genitofemoral. I won't write. See, let's remember it. Let's remember this, right? Let's just remember it. So what are the 3 nerves? Genital branch of genitofemoral nerve, nerve number 1. Second, ilioinguinal nerve. And third, autonomic fibers. Did we understand? What are the 3 nerves? Genital branch of genitofemoral nerve, ilioinguinal nerve, and autonomic fibers. Even I am unable to remember all of this, but we need to know this. Then the arteries. Which are the 3 arteries that we need to know? I think I am able to see here. Artery to vas deferens, artery to testicular artery, cremasteric artery. CTV, I don't know. Cremasteric. Arteries, cremasteric, testicular, and artery to vas. Okay, then what are the 3 facial layer? External spermatic fascia. Is it visible here? No. So fascia are external spermatic fascia, cremasteric fascia, and internal spermatic fascia. These are the 3 fascia that are associated. 3 other things are pampiniform plexus. Pampiniform plexus is what? It is a plexus of the veins. Then lymphatics, obviously, and in males there is vas, and that is all about. So inguinal ligament contains 3 nerves, 3 arteries, 3 fascia, and 3 things. Okay, do we understand this here? Also, it contains the round ligament of uterus in females and the spermatic cord in males. Does this sound familiar enough? So let's go to the next topic. This is the intraperitoneal organs. So see, intraperitoneal organs and what is the next? Retroperitoneal organs we need to remember. So let's remember just one part so that we are able to remember the second part in a different way. So my trick is to remember the intraperitoneal organs so that it becomes easy for us. So see, which are the intraperitoneal, which comes inside the peritoneum. So do you know that liver comes inside? Yes. Spleen comes inside? Yes. Does kidney come inside? No, kidney does not come. It is a retroperitoneal organ. Stomach comes inside? Yes. I have showed you. Greater omentum rises from the greater curvature and the lesser omentum from the lesser curvature. So it covers the stomach. Okay. Then for D1 is the first part of duodenum. Ileum, jejunum. Do you remember I told you about cecum and this also? Appendix. Then ascending colon is not a part. Oh, I'll tell you. Just wait. I'll tell you later. So jejunum. Then the transverse colon. And then this is the sigmoid colon. Superior rectum. Ovaries. Now, I have a question. Esophagus. Intraperitoneal, retroperitoneal? Retroperitoneal, right? Why? Because peritoneum hasn't even started where the esophagus are. Here, there is no peritoneum, dear. So, you can also use common sense. Aorta. Retroperitoneal. Why? Because it cannot be inside the peritoneum, Baba. Please understand. Inferior vena cava. Retroperitoneal. Kidney. Retroperitoneal. Ureter. So if kidney is retroperitoneal, obviously the thing that is rising from there, that is the ureter, it is also going to be retroperitoneal. Adrenal gland, retroperitoneal. So all the other organs apart from this list will be the retroperitoneal organs. These are the list of intraperitoneal organs. Do we understand this here? Okay, inferior part of rectum. Superior rectum is intraperitoneal, but inferior part of rectum is retroperitoneal. I hope that makes sense to you. Now let's talk about jejunum and ileum. See, jejunum and ileum each is 3 meters long. Okay, then arterial supply is, I have told you earlier also, the foregut, midgut, hindgut. So jejunum and ileum are foregut. part of the foregut, and foregut is supplied by which artery? Superior mesenteric artery. Okay, did I say foregut? No, this is midgut actually. See, esophagus and stomach and up till D2, this is foregut. This is supplied by celiac trunk. After D2, ileum, jejunum, appendix, cecum, ascending colon, transverse colon till 2/3 part. This is the midgut, and midgut is supplied by superior mesenteric artery, and rest after this is supplied by the inferior mesenteric artery. I told you, I think, in the previous lecture only. So we just need to know about this. What is this? So jejunum and ileum is supplied by the superior mesenteric artery. Pain fibers are referred to T9 and T10 dermatome. This is the pain. Okay, venous drainage is through superior mesenteric vein. This is all we need to know. Very small topic. Let's go to the next one. Kidney. We all know a lot of things about kidney. So this is going to be the last topic, I think, today. Then we'll be continuing the other things in maybe another class. See, my target is not to complete the entire subjects and the entire topics and the entire lectures before MRCEM. I have taken this decision out of sheer interest, and I am going to record all the lectures, all the topics, even if the exam gets over, so that people who are attempting for 2026 session, the May session, they also are able to benefit from this class, right? So let's talk about kidney, the renal anatomy. See, I'll try to record, but I also have my duties, and I don't really know if I'll be able to record as much. I am just trying. This is just my honest effort here. Let's see how long I am able to stay motivated about it. So this is the kidney, you know it, the renal pyramid, I hope you know, then the calyx, and then the renal papilla, and then the ureter. This is the kidney. Okay, these are the posterior and anterior relations of the kidney. We must be knowing this. This image is taken from Vishram Singh. If you must have read Vishram Singh in your first year, you will be able to identify it, right? So see, the right and the left kidney anteriorly are bound by different organs, right? The right kidney has liver, that is why it is known as the hepatic area. Okay, there are few things which are common, okay? Like, see, colic area and jejunal area will be common in both colic and jejunal in the lower half, and suprarenal area will always be common in the superior part. Did you understand? So three things are always common in both the kidneys: the suprarenal part, the colic part, the jejunal part. Now we need to know what else. So what lies on the right side is the kidney, is the liver. So hepatic area and duodenal area is extra in the right side. In the left side, what is there? The stomach, the spleen, and the pancreas tail. So gastric area, splenic area, pancreatic area comes towards the left side. So that is the anterior relations of the kidney. Let's talk about the posterior relations. It is super duper important. So the diaphragm covers like more than half of the kidney, okay? The 11th and 12th rib and the diaphragm. This is how it is. Now let's talk about the muscles. So there are three muscles which cover the kidney in the posterior aspect. Since it is a retroperitoneal organ, so the posterior abdominal wall lies just posterior to the kidney. So which is the lateral most muscle? That is the transversus abdominis, then quadratus lumborum, and then psoas. So the medial most is the psoas, and then the quadratus lumborum, and then the transversus abdominis. So in the lower half there are muscles. So three muscles we've done. Then there will be subcostal nerve and vessels. Subcostal means T12. See, whatever is supplying to the T12, the last one, 12th rib, they have named it as subcostal. I don't know why. What fun they were getting, I don't know. So since 11th and 12th rib is there in relation, so obviously its nerves and vessels is also going to be in the relation of the posterior kidney, right? Then there are nerves also. Which nerves are there? Iliohypogastric and ilioinguinal nerve. Let's revise quickly. The nerve supply of external oblique, internal oblique, and transversus abdominis. Do you remember? The external oblique had subcostal nerve, but it never had iliohypogastric and ilioinguinal nerve, whereas transversus abdominis and internal oblique also had iliohypogastric and ilioinguinal nerve. If you cannot connect to this, you need to watch the previous video. Okay, so the posterior relation of kidney is understood. Above there is diaphragm and the 11th rib. Then there are 3 muscles. From the lateral most is the transversus abdominis, quadratus lumborum and psoas. There is subcostal nerve and vessels, and then there are 2 more nerves, iliohypogastric nerve and ilioinguinal nerve. Okay, are we clear with that? These were the relations of kidney. Nephron type, like the anatomy of nephron, I really don't want to teach it here. What is the glomerulus, PCT, loop of Henle, DCT, all that we all know. So this is just a revision series, so I cannot just keep on telling about all those things also, because then it will take forever for us to crack MRCEM. We might even become consultants and still not be able to crack the exam. So that is all for today. I'll record few more lectures. I'm targeting to do that. Let's see how I am able to do. So thank you very much, and that is all for today. Goodbye.